Welcome to the AATS and this peer review live session. The title of this session is Integrating Immunotherapy in Resectable Non-Small Cell Lung Cancer, How to Move from Complexity Towards Clarity. This session is an industry-sponsored satellite symposium and is not part of the AATS annual meeting accredited program. But welcome, and please grab your lunch and take your seats. Today's faculty, I'd like to introduce Dr. Bott Shu. Catherine is the Price Family Associate Professor of Medicine and the Director of Thoracic Medical Oncology at Columbia University in New York City. Also hailing from New York City is Dr. Matthew Bott, who's a thoracic surgeon at Memorial Sloan Kettering Cancer Center. My name's Steve Broderick. I'm an Associate Professor at Hopkins and the Kimmel Cancer Center. So again, welcome. I want to express our thanks to PeerView for providing this session, and to AstraZeneca, Bristol Myers Squibb, and Merck, who provide the educational grants that support this symposium. You can visit us online, peerview.com/immunoseattle25 to view the slides and practice aids, and of course you can join the conversation on X at PeerView. So what are our goals for today? The title said that we would be moving from complexity toward clarity. I'd love to tell you that we were going to get to clarity, but anyone who works in this space knows that we are far from there. But we do hope to enhance your understanding of the latest evidence supporting the use of immunotherapy in stage 1 through 3 non-small cell lung cancer, augment skills in identifying candidates for different immunotherapeutic strategies in resectable lung cancer, and work on how we can improve multidisciplinary collaboration to improve outcomes for patients with early stage disease. So perioperative lung cancer care has changed dramatically over the last 2 decades. It wasn't too long ago that really all we had in the systemic space, the advanced disease scenarios, was platinum-based chemotherapy. And then over the last 2 decades, we've seen the advent of tyrosine kinase inhibitors and a number of other targeted therapies. In the mid-2010 decade, checkpoint inhibitors, dual immunotherapy, and now moving into KRAS inhibition and MET inhibition, and dozens of new drugs approved every year. But what about the perioperative space? In the early 2000s, we were still debating neoadjuvant platinum chemo versus adjuvant platinum-based chemo, and then what was the role of radiation in those scenarios. We've had improvement in imaging that has helped with selection, also with staging. We've had better surgical therapies with the advent of minimally invasive resections and ERAS protocols. We now have new data in early stage disease about the equivalence and if not benefit of sublobar resections. And now most recently, approvals in neoadjuvant chemoimmunotherapy, adjuvant immunotherapy, perioperative chemoimmunotherapy, and adjuvant targeted therapy. There are now 6 FDA-approved neoadjuvant perioperative strategies, or I should say, approvals for immunotherapy in the perioperative space. In the neoadjuvant scenario, we have Checkmate 816, which is nivolumab plus chemotherapy for 3 cycles. That's FDA-approved. In the adjuvant space, Empower 010 and Keynote 091 have been FDA-approved for adjuvant atezolizumab and pembrolizumab. And then in the perioperative space, so preoperative and postoperative, Aegean, Checkmate 77T, and Keynote 671, respectively, for durva, nivolumab, and pembro. With that, we'd like to keep this session case-based, and so I'd like to introduce our first speaker, Dr. Bott Shu from Columbia, who will go through the first case.
Thank you. And thanks to all of you for having me here today. My main disclosure is that I am not a surgeon. I am a medical oncologist. So thank you for having me in your field today. The last time I stepped in an OR was like a long time ago, and I got yelled at by the scrub nurse for not remembering how to wash my hands. So, this is a patient of mine. I work with some great thoracic surgeons, so we can kind of discuss this case. 59-year-old, he's a former smoker, and he had just gotten the CT calcium scoring study, saw a 7-millimeter nodule. He was told to follow up, and he followed up later. A PET scan showed minimal FDG avidity, and then in 2019 he continued to get CTs, grew slightly in size, and then by 2020 now the nodule was 9 millimeters. At this point he had a PET CT PET scan, yeah, it showed this left upper lobe nodules. It was avid, and it showed a left paratracheal node, no other distant disease. So this was his PET and his CT. Otherwise, like really healthy guy, hearing aids, which is important for us med-oncs, no real family history, worked as a jeweler, former 20-pack year smoker, and totally healthy guy otherwise. So what would you guys like to do from here? And please answer the poll on your phone. EBUS, mediastinoscopy with biopsy, take the patient straight to surgery, continue surveillance, or I'm not sure. So he goes for mediastinoscopy. The left level 4 was enlarged and removed. No other enlarged nodes, but we checked the contralateral nodes. They were biopsied, and level 4 was positive for lung adenocarcinoma, TTF1 positive, negative for P40. The contralateral nodes were negative, and NGS, which was performed, showed BRAF V600E and a high PD-L1 of 99%. Brain MRI negative, and he was staged as a 3A, so T1BN2. And here we're going to see what we would like to do next. So we finished his staging. Do we want to take him straight to surgery, stage 3A? Do you want to start dabrafenib, trametinib, encorafenib, binimetinib, start neoadjuvant chemo with immunotherapy, perioperative chemo and immunotherapy, or I'm not sure? Let me ask my esteemed surgeons here. Matt and Steve, what do you guys think? What are you starting out with a case like this?
I'm always surprised, I guess, and I'm curious to hear your insight on this a little bit more, like what counts as a targetable mutation or not in the setting of immunotherapy, right? Because we sort of use that term generically and we say, oh, well, as long as they don't have targetable mutations, then you give them chemo IO, right? But this case and a case we had on our tumor board recently, which was a MET exon 14 mutation, I assumed was targetable, and maybe that wasn't a great case for chemo IO, but I was educated by our medical oncologist that's not actually not the case. The patient did get chemo IO. So I agree with the management here, chemo immunotherapy. I'd like to hear maybe from you or from Steve as well, like is there actual, what sort of data is there that those mutation types really are different and respond differently to the immunotherapy in that context?
Yeah, I mean, that's a great question. I think we're still, for the patients with targetable mutations, and BRAF V600E is one of the targetable mutations, we don't have a lot of data yet on which ones of these are good in the neoadjuvant setting. So the Nautica-1 is one of these like umbrella studies looking at targeted therapies. And I think for now, we're really looking at chemo IO, and those are, some of the mutations are more smoking associated than others. So BRAF tends to be a little bit more smoking associated. For like EGFR, where most of the patients have never smoked, we don't really think that IO works for them. But but this is a slightly different mutation. Mm-hmm. He is a prior smoker, but that being said, none of those are approved for that neoadjuvant setting yet. So I wouldn't give him dabrafenib, trametinib, or encorafenib.
And not chemo alone for that reason.
No, not chemo alone either. Yeah.
Yeah, from a surgical standpoint, I think it's an interesting case with the 4L lymph node. And I think you'll find a lot of variability among surgeons for how they would approach that. It's not an easy node to get to from the left chest. The aortic arch is in the way. Some folks are more comfortable than others dissecting that out and resecting it. And it sounds like your surgeons attempted to remove the whole node at the time of mediastinoscopy, which is, I guess, another approach. We probably would have, staged this with an EBUS, and there's, some variability still on the availability and timeliness of getting an EBUS done. I don't know that we would have gone with an induction strategy here. We may have gone with definitive chemoradiation followed by immunotherapy, depending on which surgeon in our group saw the patient and their comfort with the 4L lymph node. Right. Another strategy may be to give the neoadjuvant therapy and then restage with EBUS if you sort of cleared that node, or if the node was negative on the restaging, proceed with the lobectomy. Right. So not a crystal clear
answer here because of the
Curious,
lymph node.
can I sort of interrupt us for
Yeah.
a second? We have some pretty experienced surgeons in the room and maybe some in the front here. So do you think about the 4L node any different? Is that, do you approach that case differently? Sort of share some of your experience with us maybe.
Steve's making a very good point. It's a hard area to get to surgically, but I still think in this instance, I would put all my eggs on the 99% PD-L1 positivity, give him the chemo IO, hope that the nodes are negative, and go for it. He's young. He should have been operated 2 years ago, but that's another story.
Yeah, we weren't following him back then. Okay, so he actually gets neoadjuvant chemo IO. We agree with you. Not BRAF targeted therapy. We give him the chemo IO. After 4 cycles, we had some decrease in the adenopathy. The mass was mostly stable. He actually undergoes surgery, and the surgeon noted that it was a fairly straightforward surgery, no significant scarring or fibrosis. And the pathology showed invasive adenocarcinoma was 0.8 centimeters. So the primary was small, but it kind of looked ugly, right? There was LVI, 4 of 18 lymph nodes were positive, 1 level 6, 3 hilar. The treatment effect was still greater than 10% residual tumor. So at that time, he was staged as a YPT1A-N2. So not great. What do you guys want to do with this gentleman? Post-op RT, adjuvant chemo followed by adjuvant immunotherapy, nothing more to do, just monitor, or I'm not sure. And a perfectly valid answer here is I'm not sure because it's a good question. He ended up getting a year of adjuvant IO, mostly because I was worried about his ugly pathology. And remember, his surgery now was 5 years ago, so he's still doing really well today, NED, and he finished his year.
I think the RT question there is sort of interesting, right? And I think as surgeons, that kind of depends on your subjective feeling about how well you dissected that 4L space with your mediastinoscopy, right? Because I feel like if let's say it was stuck in there, you're worried about the nerve, whatever it is, you didn't really get the whole thing out cleanly. Could that be a situation where we don't really give much in the way of adjuvant radiation these days, but could that potentially be one instance where it might be helpful? I think that would be the only other thing to think.
Yeah, no, absolutely. That's why I put that one in there. I mean, we don't routinely do post-op RT, but I think for certain situations, that's why it's really important, I think, to have all these patients presented at your tumor board and have the surgeon explain to you what happened, and then you can kind of make that decision. Okay, so I'm gonna go through a couple slides, a little bit about the data based on this case. We have a couple slides just kind of looking at this perioperative neoadjuvant space with chemo IO in general. I think the thing here that I wanted to point out was that we have all of these different studies. Some are pre-op, some are peri-op. And for me, the most important thing right now is that they differ really on treatment length. So CheckMate 816, if you look at the blue, the treatment length is actually very short because it's just a neoadjuvant trial. A lot of the other trials are adjuvant or perioperative, and they have much longer treatment time. So that's a question for us as we go forward, like, do all of these patients need to get that additional year of treatment? The other thing that we are looking at is path-CR, so pathologic complete response. So after their induction therapy, when they get surgery with you guys, when we look under the microscope, is that tumor all dead? And you can see in all of the trials that the path-CR is better with the chemo IO arm versus just the chemo arm. And that's really important because I think we've seen that path-CR is a really good proxy for how well these patients do, right? So I was nervous that my patient didn't have a path-CR, so I wanted to give him additional therapy. If we look at DFS, EFS, right? If the colors are all the chemo IO arms and the chemo are the gray arms, and you can see it doesn't matter which of these studies, but it looks like the addition of IO makes everything a little bit better. If you ask me just from looking at these and looking at the data overall, and you're not supposed to compare, but in general, I think the neoadjuvant perioperative trials look better than the adjuvant trials, and so we as med-oncs always like to give our treatments kind of before the surgery if possible, because we know that after surgery, not everyone can make it back for all of their treatment. Okay, so we do all of these things, but does it actually help the overall survival? Are we just torturing the patients? And we have a couple of studies that have shown some OS benefit. One of them, this is Empower 10. This is looking at adjuvant atezolizumab. So after they've had their surgery resected, they get a year of adjuvant atezo. So if you look at the PD-L1 greater than 50%, this is really where your bang for your buck is, right? This is where the curves really separate, the hazard ratio looks really good. Technically, we're approved for greater than or equal to 1%. You see that hazard ratio is much smaller. I think most of the benefit is actually being driven by that PD-L1 high group. So for me, in my practice, I'm really only giving the adjuvant atezo for the patients who are PD-L1 high, meaning greater than or equal to 50%. CheckMate 816 is also showing OS benefit. This is from their 4-year update presented by Jonathan Spicer. And you can see that there's a nice trend towards improvement for that Nivo plus chemo arm. And interestingly, he also showed that, you can see in this blue box that we have here, patients in the Nivo chemo arm who had a path CR are doing much better than those who didn't have a path CR, right? So those are some very impressive numbers. And basically, if these patients have a path CR, they're already doing really well. You can tune in at ASCO we're all really excited to see this final analysis for CheckMate 816. Patrick Ford will be presenting that. And then Aegean is with durvalumab, with Durva. This is with the perioperative durvalumab. And you can see also a similar kind of improvement. And then finally, Keynote 671 with perioperative Pembro, you see also a similar kind of improvement in OS with Pembro. 671 did reach their OS benefit. So those are kind of the ones that have so far, we've seen survival improvements for. We're kind of awaiting a lot of the other data for some of the other studies. And so then, what does that mean? You have some OS benefit for adjuvant, you have some OS benefit for pre-op, peri-op, like which ones of these do we use? And I think that that's really where the money lies. It's not necessarily one answer for everyone. I think we have to learn how to stratify each patient based on their particular characteristics. Patrick Ford presented this last year at World Lung. They did an analysis looking at 77T, which was with perioperative Nivo, and with CheckMate 816, which was with neoadjuvant Nivo. And you can see here that they kind of combined these two studies together so that we could compare them. And what we see here, this is just the perioperative versus neoadjuvant. It looks like perioperative maybe does a little bit better, but where it really seems to shine is here where the patients no path CR. So these patients did not meet a path CR, and you can see that that hazard ratio looks a lot better, and it looks like those are the patients that really seem to benefit. And similarly, when they broke down by PD-L1 score, the PD-L1 low group also seemed to really benefit. So this may be in the future like a way for us to stratify which patients need to get that additional year of immunotherapy, which is, not easy for the patient, not easy financially. There's a lot of things that go into just an extra year of therapy, right? And then this is EFS by stage. It looks like, it looks kind of better regardless of stage. And this is 671, looking at something similar, where we're looking at path CR, and it looks like the patients without path CR again do better. So I think that that's something that we're going to really do going forward. And I'm already integrating that into my practice. So remember, my patient who did not meet a path CR, I gave him an extra year of Pembro, and now 5 years out, he's actually doing really well. In the future, we're going to have sub-Q versions of some of these immunotherapies, including nivolumab and atezo and Pembro coming out. And so it may make the burden on the patient a little bit less. Okay, so now, Matt, I leave it to you to talk about our next case.
Okay, good afternoon. As was mentioned before, my name is Matt Bott. I'm a thoracic surgeon at Sloan Kettering. Thank you for spending your lunch with us here. So I'm going to talk through another case. Ironically, this symposium, as Steve mentioned, is titled Moving Toward Clarity. The next couple cases are, I think, far from clear. So let's see what people think is the optimal treatment approach. So this is a patient that I saw, 66-year-old gentleman, former smoker, history of some coronary disease, but fortunately minimal lung-related comorbidities. I didn't put his PFTs in here, but they were excellent. FEV1 was like maybe 80%. He was diagnosed with this 5-centimeter adenocarcinoma in the right lower lobe. His PD-L1 is 30%, and his mutational analysis did not show any EGFR or ALK alterations. He did have mediastinal staging in the form of an EBUS. All of his mediastinal and even an 11R node were benign. So wondering from the audience then, in this situation, what do people feel the best treatment strategy is? Options would be either surgery alone, upfront surgery, and then adjuvant, either chemotherapy or immunotherapy. Neoadjuvant chemotherapy followed by surgery, or neoadjuvant chemoimmunotherapy followed by surgery, or I'm not sure. We gave the patient induction chemoimmunotherapy. He got 3 cycles of treatment and then started to note worsening dyspnea, right? And then he came in for a PE protocol CT scan, which looks like this. He had diffuse inflammatory changes in the right lung. He was admitted to the hospital for a workup. He did have response in the tumor, decreased from about 5 centimeters to about 3.5 or so centimeters. He had a bronchoscopy, which was actually negative for an infectious etiology, and then he had a cryobiopsy of that material in the right lower lobe that showed pneumonitis, essentially, and organizing pneumonia. So I'll ask my colleagues maybe in a second, but I think this is one area that really is unclear, as we move toward clarity, maybe something that needs a little bit more clarification, right? So at our institution, I think we're pretty comfortable giving people with node-positive disease, stage 2-3 node-positive disease induction therapy. I think we struggle a little bit more with larger tumors that are node-negative, right? And you could make the argument, we'll go through sort of the pros and cons in a second, but are those people really also the best folks for this approach? Again, with our bias in terms of historical bias in terms of giving people preoperative treatment, we would say yes, but I think this case sort of highlights some of the potential pitfalls, at least, of that approach, and that's not to dissuade you from giving preoperative treatment to patients that need it, but I think things for us to think about and discuss as far as selecting the optimal treatments for the patient. So the patient was treated with steroids. He got intravenous steroids while he was in the hospital and then went home on a pretty prolonged course of prednisone that was gradually tapered down over the course of maybe 2 to 3 months. Took a long time. The tumor has started to increase in size again. He's scheduled for surgery with me next week. So hopefully that all goes smoothly. He's off of the prednisone at this point, so I feel comfortable operating on him. I am going to repeat his pulmonary function test just to make sure, but they were pretty good to start with, so I don't anticipate any issues. This is the, treatment, the imaging after he completed the steroid taper. So I think we'll just pause here for a minute. I wanted to kind of poll my colleagues on the panel, but also maybe elicit some input from the audience. So Steve and Kathy, how do you talk us through at your institution sort of sizable tumors, node negative? What proportion of those folks are you taking right to surgery, recommending upfront surgery versus maybe multimodality therapy to start?
Yeah, like you, we're aggressive in the neoadjuvant setting. Some of these patients are going on institutional trials still, the 4 centimeter plus tumors. And the rationale for that is that we have a higher risk of occult nodal disease, right? We also have, I think, a lot of inconsistency between radiographic size and pathologic size. So it's not uncommon that I resect a 3.5 centimeter tumor and the final pathology says it's 4.2, or it's a 3 centimeter tumor with satellite nodules. Mm-hmm. And that's the setting that we use adjuvant, sort of for the surprise upstaging. But we would have done the same thing here with a neoadjuvant strategy. I wonder if, in retrospect, you identify anything that might have been a predisposing factor. Was there some occult rheumatologic problem or history of autoimmune things that you encountered?
Yeah, no, nothing that we identified. I think that's part of the tricky part, right?
Yeah.
Is it's sometimes hard to predict who's going to have issues like this and who's not.
And I think at Columbia, we would have done the same thing. We're also very aggressive with neoadjuvant. And I just gave you all these slides about why neoadjuvant chemo-IO is better. But I guess 2 points for me, like one as a med onc, like I've never forgotten the first person I've given adjuvant IO to, and then he died of pneumonitis. And it was like, it's a terrible death because they're just stuck in the hospital for so long, and everything you give, they're just on high flow oxygen. And so like it's a real thing, is one thing. I always tell the fellows that. And 2, I'm curious though what'll happen after his surgery when we look at the path response, because there is some studies out there that sometimes these patients who have these IREs, they may actually have a better response. So sometimes, like I've had a patient who developed type 1 diabetes and he had to stop IO, and then he actually never had, any more disease after that for years. So I'm curious to see. You'll have to update us after surgery.
Yeah, I mean, I can tell you just from the imaging, like it's pretty.
Is that his post? Is that his post?
I don't think he's had like a past CR, but who knows? Maybe this is some sort of immense like immune infiltration or something.
Yes, I thought that was just
the
pretty.
final path will let us know for sure. Yeah, question from the audience. Go ahead.
This is on.
And just as a reminder, you feel free to put your comments or questions also into the app and take it that way. Go ahead.
Sorry, Rafael Rocco from Cedars-Sinai. I'm sorry if I didn't hear it in the previous presentation, but tumor mutational burden. Do you guys look at that low versus high and the response with the IO with that in your decision making?
Yeah, that's a great question. I mean, I can say that when we send our NGS testing, it always comes back in the report as a matter of routine. I can't say that we really use it to select patients for treatment much, but I do sort of make a mental note of it and kind of file it away, especially if there's a situation like this where I think, what's the risk-benefit ratio to treating somebody up front? So I think it's a great question. I don't know,
Yeah.
Kathy or Steve, are you guys
Same
using
type
it?
of thing. I mean, we don't use it to decide which patients get IO, but it's kind of a proxy for, heavy smoker probably will respond better to IO. But again, it's not something we use. And in all of these pre-op, peri-op studies, like regardless of PD-L1 score, these patients still did better with the combination. So we feel pretty good about using it.
Using the medications, like
Yeah,
even
in
in
whichever-
a low TMB case.
Exactly,
Yeah.
or low PD-L1 or low TMB, yeah.
Steve, how about you guys?
Same. It's reported, but it doesn't impact our decision making. And I think it's been really variable in the studies that have annotated their data sets for TMB. That the data is really mixed as far as the impact on response or the association with response.
Okay. Anybody else want to make any comments about the case before we keep going? Oh, go ahead.
Hi, quick question, Ori from Israel. If this similar patient had a borderline PFTs, would you consider IO at that point?
Yeah, so that's what I'm going to get into in the subsequent slides, right? So there's got to be some kind of decision making where is the risk outweigh the benefit, right? And if his PFTs were marginal to start with and it's a completely resectable tumor with negative nodes, like maybe that is a situation where I go right to surgery. But fortunately, I could have made the case maybe even more unclear, less clarity by sort of tweaking that a little bit. But I agree with you. I think there's a point where it becomes counterproductive maybe. But maybe a quick one before
Hi,
we...
John Kuckelman, Tacoma. I just curious about when you get into the situation where the timing is not ideal. Is there any preoperative or intraoperative decisions that you're thinking about before you go in? Like, I'm going to do a flap for sure now that I'm 6 weeks, 8 weeks out, 10 weeks out, anything like that? Any special considerations in these situations?
You're talking about like the timing of surgery when there's a...
Right, like ideally I'd like to go 3 to 6 weeks, but you're in this situation. I'm not sure when you're actually going to go
Yeah.
after your last dose, and
and
how does that change your operative plan?
Sure, and there's a question in the chat along those lines as well, which is like, what's the optimal time for surgery in these patients, right? And I've heard people talk about the fact that maybe going sooner is better than going later, and I sort of agree with that. I don't know that there's a ton of data to support it per se, but fortunately this guy doesn't we don't think anyway, doesn't have nodal disease, but if he had big bulky hilar lymph nodes, and now we're talking about doing surgery 6, 8 weeks, 12 weeks later, whatever it is, that's a situation I think I'd be a little concerned about. But I think in general, to your point, like I think the sentiment maybe is that sooner may be a little bit better than later, for sure. So, all right, I'm just going to move through some of these slides pretty quickly, but so the crux of the case here is sort of selecting the optimal approach for the patient. And again, there were a number of patient factors in this case where we felt pretty comfortable giving preoperative therapy. These are things that we as surgeons think about all the time, right? Finding the appropriate patient, thinking about how to sequence the treatments, where does surgery fall in the treatment course? Have you done the appropriate workup in terms of imaging and preoperative mediastinal staging? We as surgeons now are sort of obligated to really understand, I think, the data, which is why I think events like this are valuable. And then what kind of technical challenges do we need to bear in mind, in particular, as we're factoring all this in? So things we might think about in terms of selecting patients, right? So you're going to do your standard workup, right? Imaging, probably do mediastinal staging and a brain MRI where it's indicated. Then you factor in physiologic information about the patient to assess their medical operability, right? Do they have reasonable lung function, minimal comorbidities, they have good functional status? There's a biomarker testing component now that's very important, right? Because remember, we're generally not giving immunotherapy in the preoperative setting for patients who have actionable mutations, namely EGFR and ALK, as Kathy was talking about earlier, and PD-L1 status. So we at Sloan Kettering feel pretty strongly that those decisions really are made within the context of a multidisciplinary team, surgeons being an important component of that team. And they will, as a collective team, discuss all the things we mentioned: staging information, what sort of operation do you think you're going to need to get that tumor out, histologic information with our pathologists, and then, it's really then falls on the surgeon from a performance status basis, like, how likely is it that this patient would have morbidity after surgery based on their comorbidities and their functional status. So putting all that together, I think, is really important. Just a slide to sort of plug the idea of using multidisciplinary teams to assess your patients. I think fortunately most places have some version of this, and there is actual data shown here to suggest that patients treated within an MDT really fare better than those that are not. Maybe imperfect studies, but I think an important sentiment nonetheless. So what are the kind of pros and cons to some degree of each of these strategies? So the neoadjuvant strategy, the adjuvant strategy, taking patients to surgery up front and then giving them chemotherapy or immunotherapy as well afterward, or this perioperative or turn-tier sandwich approach. So in the neoadjuvant, giving the medications early, you have the ability to eradicate micrometastatic disease early in the treatment course. Patients are in a better position to tolerate their systemic therapy if you haven't operated on them yet, particularly if their performance status is a little bit marginal. We know from studies that they're more likely to complete that systemic therapy course. And then there's this idea that maybe with the tumor in situ and all the lymph nodes in place, is the immunotherapy able to work better? There's not a ton of data about that in lung cancer as of yet, but there is some data in other tumor types like melanoma where that actually is the case or seems like the case. Benefits of adjuvant therapy: you get the patient to surgery quickly. You can use the pathology maybe to guide you a little bit more. You don't have to worry about post-treatment fibrosis and these other things that can make surgery a little bit difficult. And you don't run the risk of losing a window of operability because of tumor progression. Now, you could argue that if a patient progresses during their systemic therapy, they're probably not going to do that well anyway, so that's something to sort of keep in mind. But still, that's one of the, I think, rationales for doing surgery first. And then the sandwich or perioperative approach kind of combines, to some degree, some of the advantages of the neoadjuvant with the adjuvant as well. I'll just say a few quick things about quality of life. This case did involve a treatment-related adverse event, but for the most part, what the studies have shown is that there really isn't a dramatic difference in quality of life for patients treated with chemotherapy alone versus combined chemoimmunotherapy. This is data from Keynote 671 that looked at quality of life. You can see it's essentially equivalent. And then similar data from Checkmate 816. You can see in these curves whether you're doing the operation open or minimally invasively, there's always a dip after surgery. And then in both the chemo and the chemo IO groups, that comes back to baseline, usually within 3 to 6 months. Similar findings, lobectomy. In this particular data set, pneumonectomy actually was associated with higher quality of life in the chemo Nivo group. Again, not entirely sure why that is, but something maybe to consider moving forward. And then my final slide before I turn it over to Steve. So this is data from Checkmate 77T, looking at something called time to definitive deterioration, which is hard to say, first of all, but has something to do with symptoms during the course or after treatment, right? And basically the takeaway from this is that in patients in the nivolumab group, they felt better longer. They had fewer cancer-related symptoms, presumably because their cancer was better controlled, right? I imagine that disease recurrence drives a lot of the symptomatology, but it's reassuring nonetheless to see that they didn't feel worse getting the immunotherapy. So again, important to know. And with that, I'll turn it over.
Before you step down,
Yes, ma'am.
the audience has a couple questions about your case.
Okay, all right.
One person says, would you perform a sublobar resection as opposed to a lobectomy given the higher risk of recurrent pneumonitis post-op with the latter in this case?
No, I think just based on the size of the tumor in this case, I think he needs a lobectomy in my mind. And again, I think I'll see what his postoperative pulmonary function looks like. But if it were particularly terrible and I was trying to think about could I do like a basilar, total basilar segment and spare the soup seg, I guess I could think about that. In my experience, it doesn't really save a whole lot of lung parenchyma. Yeah, I personally, I think he's going to end up getting a lobectomy, but I'll see what his PFTs look like.
Okay, and then someone else asked you, why not just radiate?
Yeah, because I think he's operable at this point, right? And I think in my mind, particularly as a surgeon, that surgical resection is optimal therapy for a patient like that if they are medically and technically operable. I have had patients I've explored, and we can talk about it during Steve's case, where they were unresectable at the time of surgery, and they would not tolerate, let's say, a pneumonectomy. We did give them adjuvant radiation, and we can talk about it later, but the outcomes actually weren't as bad as I thought they might be. So it is, I think, an alternative, but I like the idea of operating on this particular patient. So.
Okay, great, thanks. I always tell my patients if surgery is an option, I prefer it over RT because you actually get the pathology, right? And you can find out if the patient had positive N2 nodes afterwards or whatever it is you see, right? The path CR, you get all of that information, which you don't get with just radiation.
Great, so we'll move on to the third one. I think Matt's case sort of skewed into earlier disease, and I'll go into more locally advanced disease. So this guy was young. He's a 44-year-old police officer who just had a persistent cough, several rounds of x-rays, antibiotics, steroids, all that, didn't improve. Finally had a CT that showed a 14 by 8 centimeter mass in the left upper lobe extending into the left hilum. FTG avid with an FTG avid AP window lymph node. Really fit guy. FEV1 of 3.3 liters, normal diffusion capacity, normal echocardiogram. He had a percutaneous biopsy done at an outside center that just showed a poorly differentiated non-small cell carcinoma. PD-L1 was negative, no targetable alterations. We did an EBUS, which was negative at 4L, 7, and 11L, and the brain MR was negative. Here's a few sort of select images here. You can see this large mass that extended into the hilum. It sort of wrapped around the interlobar PA. You can't really distinguish whether that's hilar nodal disease or the primary tumor. But the hilar nodes that they did biopsy at EBUS were negative. And then in the center panel there, you see that 2 centimeter or so mediastinal lymph node abutting the arch or the great vessels there. So what would be your treatment strategy for this patient? So this is T4N2, and by the book, this is stage 3B, and traditionally that is a non-operative scenario. So would anyone favor definitive chemoradiotherapy and then immunotherapy, the Pacific protocol? One person in our tumor board suggested exploring the patient, biopsying the level 5 node and proceeding with resection, whatever was indicated if that node was negative, but backing out if it was positive. Neoadjuvant chemo followed by resection, even if you thought you had to do a pneumonectomy. Neoadjuvant chemo IO followed by resection, again, even if you thought you had to do a pneumonectomy. Or neoadjuvant chemoradiotherapy followed by surgery. Matt, what do you think? How would this be approached at Memorial?
Yeah, I mean, I would certainly lean toward giving the patient preoperative treatment. Seems like chemoimmunotherapy. I would be, I think there's a portion of folks, and we can talk about this later, that maybe 20% or so that don't end up proceeding to surgery, at least partially because of progression. So I'm always sensitive, to that. And if we lose a window of operability here, but I would get the sense based on the case he presented that he would respond reasonably well. And I personally don't see pneumonectomy as a firm sort of contraindication to exploring a multimodality approach in him.
Great. Kathy, any other thoughts on this one?
I think similarly. I mean, he's young, and we want to give him the best chance possible for cure. It is a very advanced disease, but technically is curable. And if he's technically resectable, I think that would still be my go-to.
So we felt the same way. He was treated with 3 cycles of chemo IO. He sailed through that, no problems whatsoever. And we took him to the operating room for a left pneumonectomy with nodal dissection. Those nodes up in the AP window, the station 5 and 6 lymph nodes were that was difficult. And, it's a little uncomfortable when you're sharply dissecting lymph nodes off the phrenic and the recurrent nerve. But we were able to do that safely. The path was interesting. I'll tell you one other thing perioperatively, something I learned from this case is, and you can see it in the CT that there's a lot of debris in this tumor. It really sort of cavitated a lot with that treatment. And as we were doing the bronchoscopy, as we were getting ready to place the stapler on the left mainstem bronchus, a whole lot of sort of necrotic debris was coming out of that left upper lobe and soiling the right lung, which was something I learned from this case that maybe as we're seeing systemic therapies that work better, we need to be a bit more careful about that in the operating room. Pathology was really favorable. He had of that 14 by 8 centimeter tumor, the pathologist found a single 1.5 millimeter focus of residual viable tumor, and all the nodes were negative. So we had cleared the lymph nodes and had a remarkable response in the primary tumor.
Steve, I think it also sort of underscores the point that you can't always predict, and we were talking about this earlier, you can't always predict pathologic response from imaging, right? And you can make the argument from the PET maybe that it doesn't have a ton of FDG avidity, but the CT looks pretty convincing to me that there would have been, real tumor left in there.
So what would everyone recommend as the next step for this guy? So adjuvant IO, certainly, right? We have residual disease. He's not in the PCR group technically, and so that's a reasonable idea. Adjuvant chemo didn't get anyone. I don't see a role for adjuvant chemo immunotherapy. Maybe Kathy could comment. I don't think that's been a protocol or a paradigm that we have any data to support in the adjuvant setting. Surveillance imaging only is, I don't think, unreasonable. And ultimately, that is what he selected. He is a boots on the ground out there, in the field police officer, and he aims to go back to that. In fact, he is back to that. So he didn't want to go with any additional systemic therapy, and he's sort of hoping for the best with the result he's got.
Yeah, we don't typically give more chemo post-op. So if it's given pre-op, we don't really give it post-op.
This is something that we talk about a lot now. What are the borders or the boundaries between resectable and unresectable disease, and what's okay and what's out of bounds? And I think this is in evolution. Matt showed earlier this first box, the anatomic extent of disease is obviously important, right? And staging and with T, N, and M. And what's necessary, right? What's the planned operative procedure? Are you okay with a lobectomy? Do you need a pneumonectomy, or are you able to get away with a sleeve or an angioplasty, bronchoplasty type of procedure? we're limited in what we have to offer, in terms of figuring this out. We have CT, PET, invasive mediastinal staging, certainly brain MR, bronchoscopy is an option if you're working on whether or not you're going to need a bronchoplastic operation or a sleeve. And there's really two aspects, right? Is the tumor and the lymph nodes technically resectable, and then oncologic resectability, or I would say more oncologic suitability, right? Is that operation likely to benefit the patient from an oncologic standpoint? And I think in that first 3A patient there, where you have a single station discrete nodal involvement, I think that's pretty straightforward, and the one that we would all favor neoadjuvant therapy followed by surgery. And for me, the second one as well, right? So if you have, a station 2R and a station 4R lymph node, I don't really make a whole lot of difference there, and would follow that same paradigm. I think that third one coming across the top, this is where it gets a little tricky in my opinion and experience, where you have hilar nodes, particularly hilar nodes that are a bit bulky and adjacent to the pulmonary vasculature. For me, I would still say that is a technically resectable and likely to be beneficial oncologically in that third scenario there. Multi-station N2 is another sort of debatable area. We're aggressive in this realm as well, particularly in patients with favorable responses to therapy or likely to have favorable responses to therapy. I think that's resectable disease and likely oncologically beneficial. As things get a little bit tougher with technical resectability when the nodes get bigger, right? And anybody can argue about what the definition of bulky lymph node is. It's sort of like, beauty. It's in the eye of the beholder, but there are certainly nodes that are bulky and can be more technically challenging to remove. But if I see a tumor in the right upper lobe with a single station bulky 4R lymph node, I'm still planning on a neoadjuvant strategy in that setting. Just bearing in mind what may be necessary to complete that nodal dissection. I don't think we have any real data in the chemo IO area specifically for Pancoast tumors. There were only a handful in 816 that I know of. I'm not sure about the other trials, and so I can't speak too much about that second one there with a single station lymph node in Pancoast tumor. I think at our center we would probably favor definitive chemoradiotherapy, followed by IO, a la Pacific. And then when we get to the ones that are really sort of unresectable, it's these really infiltrative, bulky lymph nodes where you're unlikely to get it off of a central vascular structure or central airway. And then certainly that last case where you have bulky nodes that are sort of a conglomeration of positive lymph nodes, that's an unresectable scenario. This is kind of just another way of stating the same thing, but I would highlight the first 2 points, that all of this is really variable, and it's based a lot on the surgeon's experience and the degree to which they're comfortable with these operations and their risk tolerance, as well as the patient's wishes and the patient's risk tolerance. And I think that we need to be sort of straightforward and open with patients about what these operations entail and get their opinion and their priorities on what's important to them and how they're moving forward. We look at baseline physiology, of course, looking at PFTs, VO2 max when it's necessary, VQ if a pneumonectomy is on the table, and all the other things listed there. And that helps us to figure out what this patient might look like post-operatively, and then again, go back to their priorities, right? What do they like to do? Where do they live? What are their job considerations in terms of their risk tolerance for surgery? Feasibility of an R0 resection at baseline and based on expected response. I think this is a tough one. I seldom will look at a patient who I think is unresectable preoperatively and say, we're going to give you chemo IO and then see how it goes and maybe resect you. I think this does come into play when you're looking at a lobe versus a pneumonectomy, right? If the patient's fit enough for the pneumonectomy, you'd say, well, we'll treat and then explore you, and maybe we get away with a lobe, maybe we need to do the pneumonectomy. But these are the types of considerations that I think should happen preoperatively, both with the patient and in a multidisciplinary evaluation. And then we need to sort of compare the risk-benefit profile of surgery and what we can expect from that course with the alternatives, right? And so sit down with the patient and say, this is what you might expect with Pacific, and this is what you might expect with a perioperative therapy perioperative immunotherapy. These are just two things to highlight sort of technical complexity. The one on the left was a study by Brendan Stiles looking at how difficult was the operation, or what was the degree of, we use the word fibrosis. I don't know if that's really the right word, but how stuck were things in the hilum? And the surgeon had to sort of say, was it a minor degree, a moderate degree, or a major degree? And it wasn't dramatically different between neoadjuvant immune checkpoint inhibitors and neoadjuvant chemotherapy. But what they noted was that moderate to major was pretty common when you had node-positive disease, and that fits with response to therapy. And then the other study, the NeoStar study, when they conducted that at Anderson, the surgeon had to say, give sort of this complexity rating. These are nivolumab or nivolumab and ipilimumab. So both groups got immunotherapy, but the takeaway here is about 40% of these lobes, the operating surgeon thought was more complex than sort of your average lobectomy. What about adverse events and surgical difficulty? This is just a slide from the 816 presentations that we've all seen plenty of, showing that there was no difference between the two arms, whether the patients received Nivo with chemo or chemo alone, in terms of treatment-related adverse events, surgical adverse events, or operative time. And in fact, the operative time is sort of used as a proxy for technical difficulty, and the Nivo chemo cases were actually on average shorter than the chemo alone cases. This is another study from Anderson, just looking at sort of what makes it hard after neoadjuvant therapy. This is patients who had, the majority actually received chemo only, a handful of patients who received chemo IO, and these are all node positive patients. And the sort of takeaway was that it's N1 nodes and response to therapy that were associated with the surgeons having to do sort of more advanced techniques or maneuvers in the operating room to complete those operations. This is one of a case that is a demonstrative case that Jessica Donington uses in many of her talks. This is a patient with sort of a bulky right upper lobe tumor that you see in the top left there, with a significant radiographic response to therapy. And she said, well, what is this going to look like going into the operating room, and how is she planning for that operation? And so, I think it's certainly reasonable to start this with a minimally invasive approach, bearing in mind that there's a reasonable chance that you may need to convert to open. I don't know, we always have the minimally invasive instruments and open stuff in the room for all of one of our cases. This isn't a case that you sort of add on whenever there's a little spot open in the operating room and you end up with like the intern or R2 du jour showing up to help you, or an experienced PA, right? You have to plan for this and have your fellow or have a partner or have a strong assistant who's going to be there and be capable enough to help you do this case safely. Allow enough time to do this. Certainly reasonable. Go ahead, MIS. There are a number of pretty facile MIS surgeons around. Some of the robotic guys I'm sure would be able to do this robotically. Look for metastatic disease and start working. And then as you're progressing, if it's going great. And if it's not, if it starts to feel unsafe or there's some problem, then you can certainly convert to an open procedure if necessary. Last slide for me is just to highlight something that I mentioned a little bit earlier with post-treatment injury imaging. So if you look at the grid on the left-hand side there, this was described by Boris Sapesi, something called nodal immune flare, and essentially saying that imaging may not be reliable, right? And so that's a patient who, you can see the top line of scans there showed, some adenopathy, a little bit of it FDG avid, and that, to the uninitiated, that looks like progression on the post-treatment scan. But it wasn't. It was all just nodal immune flare. Whereas, the other side shows true progression. So when you see this on restaging imaging, you have to sort of really adjudicate that probably with repeat biopsies.
So if your lesion shrinks on chemo IO and the patient no longer needs a pneumonectomy, do you still do the pneumonectomy?
That's a great question. I am personally, without data to support this, I am a believer in doing the operation that you thought was indicated based on your initial diagnostic imaging. And why is that? Well, if you had tumor that clearly crossed the fissure from the upper lobe into the lower lobe at the time of diagnosis, well, you had disease in that lower lobe, and you have no real way of knowing that you're going to have a complete path response or not. And so if you just do the upper lobectomy, you may be leaving disease behind. On the other side of that, if you have a tumor that's sort of, adjacent to the main pulmonary artery, and you say, well, I may need to do a pneumonectomy just sort of because I don't know if I'm going to be able to dissect that away from the PA safely. And you give induction therapy, and that tumor responds, and you go to the operating room, and whatever the technical indication that was going to require a pneumonectomy is sort of better now, then I think it's reasonable to downgrade that operation.
I think there are just a couple other really good questions. I think maybe Kathy can speak about a little bit of this as well. Percentage of patients that don't respond to chemo-IO is one question. And then second one is, borderline resectable cases, which I think people are trying to investigate, but it's a difficult topic to explore in the context of a paper. So what is there harm, I think is what the question is saying, in terms of taking somebody who is borderline resectable, giving them chemoimmunotherapy to see if they're responsive, and then if they're unresectable at the end, adding on RT. We touched on it a little bit with one of those cases, but maybe you guys could enlighten us about that.
So I always tell the surgeons at my institution that the chemo shouldn't really be for downstage. Like if you didn't think the patient was surgically resectable beforehand, let's not do the treatment to get this patient to surgery, because then you're giving, say the patient is no longer surgically resectable even after you've given them the treatment. Now you've given them an inferior treatment because you would have given them concomitant chemoradiation previously, and now you've given them chemo-IO, and then now what do? Do you give them RT? So,
and I would add, that's a lot. Right?
Yeah,
That is a lot of treatment, and trying to do that backtrack where you've had 3 or 4 cycles of chemo-IO, and now we're going to change the plan and do chemo-RT.
And increased risk of pneumonitis.
Oh, and by the way, a year of IO after that, that's a lot of treatment.
Yeah. So we try really hard, like if the patient's not resectable, like I really ask the surgeons, like, do you think this patient could be resectable now? And if not, then we go towards chemo-RT.
And how much data is there, if you're forced into that approach, I mentioned this earlier, and you're sort of pivoting to post-op RT, is there data to say how those patients do, Kathy? What's in the literature? Do you happen to know?
No.
I mean, I'll just say
sure.
I've seen some abstracts sort of floating around, nothing that's really published data, again, suggesting they do okay. So I think it makes me feel better as a surgeon, like if I manage to not do a complete resection, there's still hope, I think, for the patient. Not to say that every patient should be approached that way with radiation as sort of a backup plan, but I think in the event that you run into it, it's okay.
Yeah. No, I agree. I mean, I think anecdotally it's fine, but that's what we try and do.
Dr. Shu, we're over by
over
a little,
time.
but we can do 1 or 2 more. Do people who have a targetable lesion and get immunotherapy have a higher risk of pneumonitis?
Yeah, so that's a great question. There is data showing that people who have gotten IO in the metastatic setting, and then you find out they have like an EGFR mutation, so you give them like osimertinib after that, they do have a higher risk of pneumonitis. So I'm always pretty careful. I don't give people, I always want to see a full like next-gen sequencing panel before I give IO, exactly for that reason.
And another, I think, good question for you, Kathy. Adjuvant targeted therapy like dabrafenib for the patient that you, is that a covered approach?
Not yet. So far, the only targeted drugs that are approved in the adjuvant setting are for EGFR, so osimertinib, and ALK, alectinib. But there are ongoing studies.
There's a question in here. Does your decision-making for postoperative therapy differ, or is it influenced by whether or not the patient has received neoadjuvant therapy? And the answer there is yes. The adjuvant component of the perioperative paradigms is usually immunotherapy alone, whereas if the patient didn't receive neoadjuvant therapy and has a surprise nodal disease or something along those lines, oftentimes we'll use chemotherapy and then immunotherapy after that. So yeah, that does matter.
And a quick question about biomarker testing from small biopsies. Yes, in general, it's feasible either from forceps biopsies or core biopsies, probably about 80% or so of the time, the data would say. So.
Yeah, and we're getting enough just from our eBus, from our IP friends too. So.
Right, well, I think we do need to wrap up there. Thank you very much for joining. Thanks again to PeerView for organizing this. You can visit us online and complete or submit the post-test and evaluation for your CME credits. You can also download the slides and the practice aids, and you can watch a replay of this event if you so desire, because it was awesome in the coming weeks. So thanks again for joining us, and you can follow along on Twitter at PeerView. Thanks again.